For our next session, we would like to invite on stage moderators Dr. Rajesh Pasricha, Dr. Ajesh Bansal, and Dr. Mihir Mohapatra. As chairpersons, we would like to invite Dr. Kammal Lamichan, Dr. Kumar Ratnesh, Dr. Vinod Kumar, Dr. Rajiv Gupta, and Dr. Yubraj Sharma. As speaker, we would like to invite Dr. Naresh Agarwal.
Yes. Good evening, everybody. And my sincere thanks to Dr. Professor Anil Arora, Dr. Praveen, Dr. Ashish for inviting and giving this opportunity. And it's a blessed day to pay gratitude to my teachers. Dr. B.C. Sharma is there. I did my DM with him. And my talk will patch up between Dr. Piyush and Dr. S.P. Mishra, bit patch up, because this will be acting as a buffer. If we see this simple looking instrument, that is a pH impedance channel, that has changed the way that we approach and shape our patients of GERD. And that has brought all these issues in context. Before going to the talk, if we see these tracings, on left side, at the time of reflux, there is a fall in impedance, and that fall ascends upwards as the reflux ascends. At the same time, there is a fall in pH. But in contrast, on the right side, there is a reflux, there is an ascent of fall in impedance, but there is no fall in pH. And that is how this instrument differentiates between the contents of the refluxate between acidic and non-acidic. And this is the background of a non-acidic, or we were talking of voluminous reflux, is there. The symptoms of GERD, the classical symptoms, can be there without GERD also. Like, for example, in esophageal dysmotility or eosinophilic diseases, functional diseases, or hypersensitivity. But reflux, which is happening as a pathological disease, can contain either acidic contents, non-acidic secretions of stomach, or ingested contents, bile, duodenal contents, and so on, or a combination of these. What we are talking about is the non-acidic component. But there is a catch in definition. Non-acidic does not mean the pH is more than 7. We agree that pH is less than 4, it is called acidic. And chemically more than 7 is alkali or non-acidic. But there has not been any consensus what is non-acidic reflux. So colloquially or collectively, the area in between, which is called in literature as weakly acidic, collectively with alkaline, is called as non-acidic reflux. So this is an entity which can be diagnosed on pHmetry, not clinically. And this is a collective term containing weakly acidic and alkaline contents of the refluxate, calling it non-acidic reflux. Prevalence. We do not know the prevalence of non-acidic reflux because nobody will do pHmetry at the beginning of start of treatment. But we know how it happens in those patients who are treated with PPI. A patient who is a patient of GERD who is responding to PPI, around 50% of them will have a non-acidic reflux. But if a patient group or cohort is refractory to PPI, majority of these patients will have non-acidic reflux. So non-acidic reflux may be more relevant or more clinically significant than acid reflux, what we talk day in and day out. In NERD patients, Dr. Nitin was just talking, it's more relevant, and most of the patients of NERD patients may have non-acidic reflux, particularly in the nocturnal period. How is it relevant? Why we are talking of non-acidic reflux? First is voluminous reflux. And the effects of volume leading to the consequences of reflux disease are more relevant and more pertinent with non-acidic reflux. It is a primary cause of PPI refractory disease. It forms more than 50% pool of NERD patients. More closely associated with respiratory diseases, cough, asthma. In fact, lung transplant cohort was the main leading trigger factor when the non-acidic reflux came into context. It is more closely attributed to graft versus host disease in patients receiving lung transplantation, treated adequately with PPI, still developing pulmonary diseases. It has also been attributed to development of squamous cell carcinoma of esophagus, and it has been seen in a small oncology trial that patient treated with PPI squamous cell carcinoma was patients having more of non-acidic reflux than acidic reflux. And the same has been shown in this graph. Why non-acidic reflux happens? Actually, PPI therapy is the primary cause of non-acidic reflux. It converts acidic into non-acidic reflux, but it does not control the volume, or it does not control the number of refluxes. Gastroparesis, meal ingestion may be these physiological factors causing non-acidic reflux, but they are not pathological. One important factor of non-acidic reflux is atrophic gastritis, particularly by H. pylori, where there are no proton cells to form acid. Biliary reflux, another disease, it is an entity in itself, so usually not classified as non-acidic reflux. As I discussed, acid suppressive therapy is the primary cause, and in a study it was found that PPI treated patients, 82% patients were converted to non-acid reflux from acid reflux disease. In a multicenter study from US, which was published in 2006, it was found that PPI treated patients, majority had non-acidic reflux. So acid suppressive therapy is the primary cause. There may be another, and this was also seen in the 168 patient series from US, that after treatment of GERD with PPI, around 37% patients were having non-acidic reflux, whereas 11% had refractory PPI acid reflux. Structural factors, TL-ACR is the most common and most pathological factor contributing to non-acid reflux, hiatus hernia. Disruption of any cause causing disruption of LES, reduced clearance is very important cause of non-acid reflux and associated diseases. Decreased saliva and esophageal secretions like in Sjogren or autoimmune diseases. Increased sensitivity of esophagus, decreased permeability of esophageal mucosa leading to injury in the submucosa and muscularis propria of esophagus, and reduced gastric emptying. What are the symptoms? Symptoms are hallmark symptoms of regurgitation and reflux are still the most common symptoms of non-acid reflux. But regurgitation and esophageal hypersensitivity is more closely attributed to non-acid reflux than acid reflux, because there is no chemical damage, it is the volume damage which is, and as we ascend in the esophagus up, the organs like larynx, bronchus becomes more sensitive to non-acid reflux. So this is the volume and chemical nature. Extraesophageal symptoms, as discussed, throat clearing, voice changes, globus, and cough, asthma are very common in non-acid reflux. But when we try to identify patients of non-acid reflux, there are challenges. 24 hours pH metry may be inadequate, so a wireless pH monitoring may be required. And the gold standard is still pH metry, but challenges of time are there. And another challenge that there is no consensus on non-acid reflux. You will find literature, 80% of them is acid reflux. Leon consensus identification of acid reflux is there, but little is talked about non-acid reflux. So it has been agreed by the clinicians, researchers all over the world that these three factors will identify a patient with non-acid reflux. This is a consensus, not the guidelines, that if the impedance events on the number of refluxes is more than 80, leading to fall in impedance, acid exposure time is less than 4%, which will categorize in acid reflux, so it should be less than 4%, and a positive symptom association. These three criteria will be there for the identification of non-acid reflux. So if we find a patient of esophageal symptoms or non-esophageal symptoms of non-acid reflux, straightforward head towards 24 hours pH metry, probably a wireless pH metry if available, and then we can categorize between non-acid reflux and acid reflux. But there will still be a group and cohort which will not be categorized. For example, if the reflux rates are more than 80, acid exposure time is 4 to 6%, then we are in between. So this will be an indeterminate group. How do we treat? These are the treatment heads. Lifestyle changes, taking advantage of gravity, bed head elevation, meals. Actually, non-acid reflux is with the limited therapies. In acid reflux, we have PPI and PCAPs, which are dramatic therapies, but in non-acid reflux, therapies are limited. Enhancing acid, on the contrary, orthodox is that acid suppression is the primary cause of non-acid reflux, but acid suppression is still the first choice of treatment. If patient is on single daily dose, we have to increase the dose of PPI. We can add H2 arrays, and it has been shown in this study that adding another dose of PPI will reduce the symptoms of patients with non-acid reflux. At least 50% of patients with non-acid reflux will improve with PPI. Baclofen, Dr. Piyush was discussing. Baclofen is a GABA B2 receptor agonist. It reduces TLESR, increases LES tone, reduces acidic and non-acidic refluxes, and improves the symptoms of the patient. Buspirone is another agent. I don't know, but baclofen is uncommonly used in patients with GERD. There may be 10 to 15% chances that the patient has to stop therapy because of prominent side effects, particularly dizziness. And in this study, the number of refluxes were better. There was a meta-analysis, and it was shown that the number of refluxes was much better than controls. Acid exposure time improved. Incidence of TLESR improved. But the adverse effects were statistically not significant, but in a given patient, it may be troublesome and patient may have to stop the therapy. Alginates. Alginates have been talked about much these days. They form a raft and increase the viscosity of gastric contents. They make it thick. They neutralize the pepsin and other non-acid substances in the stomach. They reduce the reflux rate, and thereby they reduce the symptoms. And the good news is that they have zero side effect. They can be used in pregnancy also. So a very good therapy for non-acid reflux. Esophageal hypersensitivity goes without saying, because many patients will have a psychosomatic overlay and use of either tricyclic antidepressants, SSRIs may improve the symptoms. Those who are not even responding to these therapies. In a small study, actually all the studies in non-acid reflux are very small, and they are case series. Few randomized trials are there. Prokinetic agents will improve symptoms, but only in patients who have either motility disturbances of esophagus or gastric motility disturbances. And they do not reduce the number of refluxes or refluxate, and addition of mosapride or cisapride have been shown to improve symptoms a little bit. Then, since the time is limited, I am running over the slides. Interventional treatment, which has been already discussed, but there is a caveat that we have to categorize and select the patients properly. Not all patients are candidates for intervention. First, see if there is a hiatus hernia. If hiatus hernia is more than 2 centimeters, endoscopic therapy may not be that rewarding. And if it is Hills 1 and 2. If hiatus hernia is large, then surgical fundoplication should be the treatment of choice. ARMA is a very good treatment, particularly in terms of ease of doing. Technical success is around 100%. Now there is a good experience. We need still more bigger randomized trials, but it is OPD procedures, as Dr. Renil Arora said. It is a very simple procedure and good results, but the thing is to select the patient properly. In the study by Inouye, who invented ARMA or who presented ARMA first time, this is a case series and it's shown the health related quality of life is much better post ARMA, and the improvement in GERD symptoms is also there. Anti-reflux surgery in particularly selected patients. Patients who have esophageal dysmotility or problems with the symptom association on pH-metry will not properly respond to fundoplication. I don't know how many of us are witnessing doing pH-metry and manometry before fundoplication, but this is a prerequisite for these patients. So if we have a patient of non-acid reflux, we have to immediately start empirical lifestyle changes, increase the dose of PPI, adding H2RAs. If patient is failing, then we can use baclofen or buspirone. On failure, we can use tricyclic antidepressants, SSRIs, and then interventional treatment. Prokinetics are reserved for
Dr.
those
Agarwal,
with
your
motility
time is off.
disturbances.
Dr. Agarwal, your
Yes,
time
yes, sir.
is
Thank you,
off.
sir. Thank you.
So
This
can
is my
please conclude?
last slide. Yes, sir. Thank you, sir. Thank you, sir.
So, last few talks, 3-4 talks, Dr. Misra, then Dr. Piyush, Dr. Agarwal, they are, I think, are mixed up about, say, they all described about GERD, about hiatus, about pH monitoring, about impedance pH monitoring, and all these things mixing up. But can anybody give us a clear idea? So first thing in your talk was, you have to tell what is the prevalence. Please tell us what is the prevalence of non-acid reflux. Dr. Agarwal. Dr. Agarwal. 20%.
Yes, sir.
Yeah, prevalence. He told it is 20%. That is enough. Number 2 was, how do you initially think it is non-acid reflux? I think initially the thing which give you an idea about non-acid reflux is it doesn't respond too much to PPIs.
So for PPI responsiveness, that we have to wait for at least 4 weeks, because then only we can label patient as PPI refractory.
Yeah.
Yeah, PPI refractory is the group in which the non-acid reflux is suspected maximum.
And after that probably comes, say you have to tell about the transient lower esophageal sphincter relaxation, if you can objectively tell in which patients it happens. Then about whether the reflux rate, volume and the quality is non-acidic. That also you have to tell.
Yeah, that can only be judged or assessed by pH metry, sir. Because without pH metry, you cannot label a patient as logically as non-acid reflux. You can suspect, but.
And lastly, you told about baclofen. See, baclofen, whether it should be given pulsed or a single dose, 10 milligram 4
No,
times,
it has to
or
be
40
given in a
milligram OD.
periodic dose, 20 milligram twice daily or thrice daily. But as you increase the dose, so for hiccups you can use 10 milligram twice or thrice daily. But for reflux disease, 10 milligram is insufficient. In most of the trials, the dose is used more than 20 milligram twice or thrice
So
daily.
probably surgery has a role where it doesn't respond to baclofen and other things.
Yeah, surgery has a low role in select group of patients. In which
I think
they
any
have-
opinion from the house?
So, let me put everything together. Non-acid reflux is diagnosed only on 24-hour pH metry. When you do, if you have a AET less than 4, it is non-acid reflux. Non-acid reflux would again be subclassified into different types: the functional reflux, reflux hypersensitivity,
Pathological.
and there you will have this group where
It's only
it was shown that the
pathological if you
Leon
have
2 consensus shows that if you have more than 80, it's actually more than 73 episodes of reflux per 24 hours, these are the patients who have NERD, but these are true refluxers
But with symptom association, because
With
patient may
symptom
have more than 80
association.
refluxes with no association
with symptom
symptoms. Yes.
association. Yes. So if you have these two things, then it is symptom association.
So all three criteria are necessary to label
if you
patient
have
as
GERD,
non-acid.
you begin with empirical PPI therapy. If there is no alarm symptom, if there is alarm symptom, you straight away go with endoscopy. No alarm symptom, 6 to 8 weeks of empirical PPI, patient not responding, then you do endoscopy. There is no esophagitis, then you do a
pH metric.
24-hour pH studies, and that is how you reclassify these patients. And for doing this, you have to stop PPIs.
So we are running late.
So PPI refractory
Well,
patients
but
you have
one
to
thing
do
is
on
important
PPI.
for most of the drugs. Our Indian patients require a lesser dose. So that can be true for baclofen too.
Yes, sir.
So thanks everybody, the organizers want that we are running short of time. So with this we close this
Session.
We
Yes,
close
sir.
this session. Yes. Thank you everybody.
And for next session, yes, thank you, sir. Since we are running late, so we will be skipping question and answers from the next session. So for next session, which is on what is new in hepatology, I would like to call the moderators, Dr. Dipesh Sood, Dr. D.K. Bhargava, Dr. Jayant Ghosh, Dr. Mitra Prasad.
As chairpersons, we would like to invite Dr. Barun Shrestha, Dr. Chitta Panda, Dr. Adya Karki, Dr. Shahina Parveen, and Dr. Prakash Chaudhary. As the first speaker, we would like to invite Dr. K.C. Sudhamshu.
Good evening. Thank you, Aurora sir, for kind invitation. I've been coming here since last 20 years to learn, and happy Teachers Day to all my teachers, from them I have learned a lot. Today I'll be talking about hepatitis vaccination, what is new. These are my outlines. Immunization through vaccination is the most effective way to control the various illness in public health issues. Vaccinations are the cornerstones of public health policy because they are highly effective and cost efficient to control the diseases. It is particularly relevant for the hepatitis virus because it can control acute illness, it can control acute liver failure, and it prevents chronic liver disease as well as hepatocellular carcinoma. So I'll be talking about hepatitis A vaccine first. So these are the timelines of hepatitis A vaccine. Hepatitis A virus was first identified in 1970s, and then came this immune globulin for prevention in 1980s. In 1990s, first live attenuated vaccine was developed in China, and subsequently it was approved in 1992. In 1991, first inactivated vaccine, Heverix, was licensed, and in 1994, dual vaccine was developed in USA, and in 2001, Twinrix, the dual vaccine, was approved by FDA. Now regarding HIV vaccine, we have two vaccines. One is live attenuated vaccine and another one is inactivated vaccine. And if the antibody is between 10 to 30, then it is said to be protective. Now, while comparing these two, the live attenuated vaccine, they contain the deactivated viruses. They causes they causes same illness, but in less degree, and single shot is enough to produce the disease. They are not indicated in immunocompromised and pregnant ladies, but in this inactivated HIV vaccine, it gives the dead virus particle, and these are slow to cause the effect and require 2 doses, and it can be given in all the individuals including immunocompromised, and these are used worldwide beside China and our country where the live attenuated HIV vaccines are given. Now HIV vaccine futures, what are the futures of HIV vaccine? It has been tried, the single dose has been tried in Argentina, and maybe we can follow it, and multivalent vaccines such as combination of hepatitis A, hepatitis B and typhoid vaccine can be used in future, and it may be needle free like intranasal or submucosal, they can be used in future, and expanded, it can be expanded in immunization program in endemic countries like Nepal, India, and outbreaks management focus in high risk group, it can be used. And let's move to the hepatitis B vaccine. The story of hepatitis B vaccine begins with the development of the discovery of SBS-AG in 1965. In 1981, first hepatitis vaccine from human blood was developed, and then subsequently in 1986, yeast-derived vaccines were developed, and then global vaccination recommendation was made by WHO in 1991, and in 1994, the bivalent vaccine was developed. In 2001, Twinrix was approved by US FDA, and in 2009, WHO declared that the vaccine is helpful in preventing the liver cancer, and in 2017, the newest vaccine of hepatitis B was developed. Regarding hepatitis B vaccine, it is safe and it can be used. The traditional one is the 3-dose vaccine, but now there are vaccines which can be given in 2 doses and have better efficacy than 3-dose vaccine that is tried everywhere. So, this is the first vaccine trial that was published in 1981, and this is the landmark trial that hepatitis B became the foundation for the hepatitis B vaccine. And in this study design, 1083 subjects were enrolled, the homosexual men in US, and they were given the vaccine which was developed from the yeast by the SBS-AG particle was introduced in the yeast, and then the product was obtained and it was given. Regarding the safety profile, only few minor risks were there, the injection site problem. Otherwise, regarding the efficacy, it was 25.6% in the placebo versus 3.2% in the subject where this hepatitis B was developed, and immunogenicity more than 95% developed anti-SBS antibody after 3 doses. And this vaccine development revolution started, and then the Nature paper that first published in 1984 used the yeast recombinant vaccine, and that is the cornerstone of the vaccine used these days. And these are the vaccine development story. The first vaccine was tried by Bloomberg himself, and he developed it in 1971, but it was not publicly used. And then came the 1981 where the blood product was used, and then came in 1986 the yeast recombinant vaccine, and then the 3rd and 4th generation of vaccines are available these days. So, this first trial combined vaccine was used in 1994, and in this study 3 different types of vaccine were used. One is hepatitis A and hepatitis B in both arms. One is mixed and another one is combined. Regarding the schedule, it was 0, 1 and 6 months. Safety factor, it was same in all 3 groups, and immunogenicity, the compared to the different in different arms, the combined and the mixed vaccine were better, and it became the cornerstone of the combined vaccine trial. And based on the 773 adults population, the 1 month after first dose anti-HAV was developed in 93%, and it was 100% after 3 doses. So, the combined vaccine is now US FDA approved and can be given in 3 doses, same as the Ingerix B which we are giving. And the first trial of Hepsilab, the now 2-dose vaccine that we are US FDA has approved, was first phase trial was done in 2003, and it was observer blind dose escalating study in which SBSAG along with ISS in different strength was used, and the trial concluded that if ISS was used in 1018 unit, the efficacy was better. And after that, the phase 2 trial in 99 adults in this Hepsilab was used, and the protection after 2 doses was achieved, and compared to Ingerix B, it gave protection to 79% seroprotection after 1 week, and in secondary doses 100% were achieved after the 2 doses. So similarly, it was used in old adults, and in 88 adults who were aged between 40 to 70 found that Hepsilab B achieved faster and higher seroprotection than Ingerix B. So these are the trials that established the efficacy, and we can see that more than 95% efficacy compared to the Ingerix B. And in another trial, it was seen that in 166 patients it was used, and in chronic liver disease patient, 34% cirrhotic patient seroprotection was achieved in Ingerix B, while it was 63% in CLD patient. So it is also effective in CLD patient. Regarding the trial in CKD patient, single dose versus double dose of Ingerix B was compared, and it was found that Hepsilab B was more efficient. Similarly, hepatitis, this was also safer in type 2 DM. Regarding therapeutic vaccine, there are few trials. Among them, NASVAC is the first one. It was tried in, it was intranasal vaccine containing SBSAG and core antigen, and the protection rate is also good one. And the 5-year long-term study also shows that the protection is durable, and up to 80% people they have cleared the hepatitis B virus DNA. And regarding another trial of GS 4774,
sir, we are running short of time, sir.
It was safe but not used. Okay, I'll be going through HEV vaccine. We have this HEV, first HEV vaccine was developed in Nepal, and it was conducted in army personnel. 1800 persons were enrolled in 2 groups, and the vaccine success rate was 85%. And the latest vaccine is the HEV 239 vaccine developed in China, and it is the long term study has proven that it is safe. And this HEV vaccine is also safe in elderly population, and the Western population recent has also shown that it is beneficial. And to conclude, this immunization through vaccination is successful. Effective vaccine against HAV and HBV are available, and this HEV vaccine is nucleated on the block, and it can be used safely further. Thank you.
Thank you, sir. We can discuss questions in later. This hepatitis E vaccine has also been marketed in India also recently, sir, and it has been come in the market.
Now I would like to invite the second speaker of the session, Dr. Anant Shrestha.
Thank you very much. Very good evening, ladies and gentlemen. At the outset, I would like to thank Dr. Agrora for inviting me here and having me let me have this talk this evening. And the topic that is given to me is pretty interesting, isn't it? How fancy does it look like? This is the itch and twitch. Now, itch is probably the worst suffering a man can have, apart from pain. And Alighieri in his manuscript described that itch was used as one of the punishment for those in the 8th and 9th circles of hell. It's disabling, helpless, distressful, affects quality of life, sometimes may even lead to suicidal ideation. Fortunately, we have 2 hands and 10 fingers. We can scratch all over our body except for the interscapular region where we hands can't reach. But then that's not just enough. So when it comes to chronic cholestatic liver disease, there are many, but then the relevant ones in our clinical practice are PBC, PSC. Occasionally we come across genetic cholestatic syndromes like BRIC, PFIC, Ehlers-Danlos syndrome. The Sarcopenias and vanishing bile duct syndromes, when we often come across in case of some DILI cases and some post-necrotic cirrhosis. There have been enigma about the pruritus, and there have been a lot of pruritogens that have been investigated, but not any one of them have actually stood the test of time. Now, it has been speculated that there remains a biliary factor or known factor that is secreted by diseased cholestatic liver that is a pruritogen. We don't know what it is, but we know a couple of characteristics that are: it is modulated by PPAR alpha agonists, bi-transformed in liver by PXR, pregnant X receptor ligands, undergoes interhepatic circulation, signals through opioidergic and serotonergic system, and pulls in systemic circulation. Now, these are neural pathways which starts in skin and reaches our brain and will be perceived it consciously as its sensation in primary somatosensory cortex through primary, secondary, and tertiary itch neurons. Management is very complex. There are a long list of agents that are used, and this also describes that not every patient responds to the same therapy, and there is a very dire need for a very strong and a very evidence-based approach or new agents. Now, ancillary measures are not very strong, or they are not very potent, but then they try to help make these people's life easier. Moisturizing, use of cold baths and showers at night, and psychological interventions for additive stretching might be helpful. Now, bile acid sequestering, cholestyramine is probably the first agent that was used for pruritus, and it is still the number one or the first line agent for treatment of chronic cholestatic liver disease associated pruritus. But if you look at the data, they're very sparse. The data that are mostly quoted are from 1984s, and these are controlled trials. And look at the number of patients: 8 patients in this trial. They were studied for 10 days and was compared with antihistamines and placebos. They were effective in these trials, but then if you look at another double-blinded placebo-controlled, and that is the only trial that is available, you can see 10 patients. So based on these small minimalistic data, it's very difficult to interpret actually how effective this cholestyramine is, but still it is considered to be the first-line agent. It comes with a couple of side effects like bloating and constipation, which is not seen in newer generation of sequestrants like colesevelam, but then it has failed to show its promise in alleviating pruritus. Now, PPAR agonist has been extensively studied in case of NASH or MASH, but it also speculated that it may have some anti-cholestatic properties. With this regard, bezafibrate, that's a pan-PPAR agonist, was studied in this FITCH trial, about 74 patients of PBC and PSC combination. And they were treated for a duration of 21 days and observed for 14 days of off treatment, and clearly showed that bezafibrate significantly reduced the VAS itch scores for both PSC as well as PBC. And when bezafibrate was stopped after 21 days, the itch scores again rose up to the level of placebo or the pre-treatment levels. In Bezoso trial, what they found was when bezafibrate was used in PBC, who were partially or incompletely responding to UDCA, not only there was biochemical remission, but there was also a decrease in itch score. So fibrates has made its place in management of pruritus. And this meta-analysis showed that not only bezafibrate, even fenofibrate may be helpful in alleviating itch. But then the potency of bezafibrate is at least about 5 times more than that of fenofibrate. As for other PPAR agonists, seladelpar in response trial have shown significant reduction in pruritus, whereas elafibranor, that's a dual PPAR agonist in ELATIVE trial, didn't show any significant reduction in pruritus, but there's trend towards improvement. Now, PXR, pregnant X receptor, a nuclear receptor that modulate different cytochrome enzymes, and it decreases bile acid synthesis, helps to improve detoxification, uptake, and excretion of bile acids, thereby being helpful in cholestasis. But the rifampicin has been used extensively in treating cholestasis, and this meta-analysis proves that it is effective as well as safe. There are other agents like mu receptor antagonists like nalmefene, naltrexone, and naloxone that have shown promise, but again, these comes with side effects of opioid withdrawal, and again, the data are very sparse, and so is with sertraline. So nuclear blockade is IBAT inhibitors or ASBAT inhibitors. These works in the intestine, prevents reabsorption of bile and breaks the interhepatic circulation. This has been extensively studied in treating inherited cholestatic liver disease like Alagille syndrome and PFIC, and actually marlixibat and orevixabat has been approved by FDA for treating these patients. It does significantly decrease itch scores as well as decrease bile acid and may have prognostic implication in patients with inherited cholestatic liver disease. But then for adults, especially for the PBC, there are very sparse data. There are only 3 trials that I can quote at the moment. The Glimmer is a dose ranging trial, phase 2b trial, where different doses of linerixibat was compared with placebo to see if there was a dose response. Primary analysis actually failed, but then on post-hoc analysis showed that linerixibat actually decrease daily worse itch score as well as monthly itch scores. And they found that 40 milligram twice daily was the optimal dose where there was a balance between the highest efficacy and lowest side effect, that is diarrhea and abdominal pain. And finally, the phase 3 trial called Glisten trial was completed. It is not yet published, but this was presented in last EASL meeting. And again, it achieved all the endpoints, that is worse itch numerical rating scales in 24 weeks, 2 weeks, as well as it has impact in the sleep quality of the individuals. And these work quite well. Its efficacy started at 2 weeks and was sustained through 24 weeks. And surprisingly, about 20% or 1/5 of this patient on linerixibat had complete disappearance of itch sensation at the end of 24 weeks as compared to placebo when it was just 9%. Volixibat is again another agent that showed similar results to linerixibat, but I'm not going into this. Those patients who do not respond to medical therapies that we have mentioned earlier would probably go into or more would require more invasive interventions like nasobiliary drainage, plasma exchange, MARS, or even liver transplant in extreme situation. But then if you look at the evidence again, there are only case reports or the most case series that have been reported regarding these interventions. As for nasobiliary drainage, it is durable for BRIC, but it appears to be very short lasting for primary biliary cirrhosis. If there is a dominant structure in PSC, it may be useful, but then apart from that, apart from BRIC, again, nasobiliary drainage has to be kept on repeating, and there comes a risk of post-ERCP pancreatitis that ranges about 30%. Plex and MARS gives transient effects, needs to be repeated again, but may be used as a bridge in extreme situation. Liver transplant is something that may be considered when there's very marked worsening of quality of life in these patients, and should be done after a proper selection for cases. So to summarize, as of now, the strongest evidence are that for bisafibrate, but it comes with adverse effect of renal insufficiency and myopathy, and rifampicin, where again drug-induced liver injury is a risk, but it's not that much as we might assume. Cholestyramine, naltrexone, and sertraline has got limited evidences, but then they still have got places in the second and third line as of our current recommendations. The place for IBAT inhibitors is yet to be defined because we just had one study that has completed a phase 3 trial. So this is the flow chart how pruritus is managed as a standard of care at the current date. The first line is still cholestyramine, though recently for PSC, bezafibrate has been recommended by EASL. Apart from that, rest of the cases, number 1 is cholestyramine. If it fails to respond, then second line would be bezafibrate and rifampicin. Sertraline and naltrexone probably would come in third line. If they fail, with all of these, probably we have to go for invasive therapy in individualized basis. That would include plasmapheresis, MARS, nasobiliary drainage, maybe UVB therapy, and in extreme cases, transplant. Thank you, and that's my 10 minutes.
Thank you, Dr. Anant, for a nice talk. Dr. Anant, is there any role of steroids?
Well,
like anabolic steroids or phenobarbital, because sometimes we use it. The intractable pruritus is one thing which we have faced.
Yeah, I was just talking about chronic cholestasis related pruritus, but then steroid may be used in hepatitis A associated cholestasis. The steroid whitewash is quite established, that is one thing. You can often use it in overlap syndromes associated and autoimmune cholangitis. They have definite role of steroids, and so does patient with IgG4 related disease. When they have sclerosing cholangitis associated IgG4, there might be some role, but these are not antipruritic effects.
Right.
It's more of anti-inflammatory, or maybe you might say the real treatment of the disease.
One more? Yes, Dr. Misra.
I was just seeing the post-CRCP pancreatitis 13 to 30%. The ballpark is 2 to 7%. Why is it higher in these patients?
So there's a couple of things that could be, because the real indication is not a biliary obstruction. You usually see higher incidence of pancreatitis when actually ERCP is not required, number one. Number two, the incidence of pancreatitis, what they report in these studies, actually not clinical pancreatitis, but raise in amylase, the rise in amylase post ERCP. So that could be one of the reasons why the incidence is pretty high.
Yeah, Dr. Chauhan.
Yeah, but then
last question.
So what precautions and you tell the patients when the patients are receiving cholestyramine, they also receive other drugs? When should other drugs be administered as far as use of cholestyramine is concerned? This is one. Other is rifampicin, and even fibrates, for example, have some hepatotoxicity. So how do you monitor these patients over a period of time?
Yeah, that's a very good question. Now, the first question was regarding dosing of cholestyramine. That's very important, especially most of these patients are already in UDCA, for example, those patients with PBC. So for this patient, at least spacing for 3 to 4 hours is very important. And it's preferable that cholestyramine is taken along with food. That probably helps out. Regarding monitoring of hepatotoxicity becomes very, it's very tricky, especially when you already have raised bilirubin. And the bilirubin, rising bilirubin and worsening of clinical condition, and these two things needs to be monitored pretty well.
Any role for ondansetron? There is a 5-hydroxytryptamine antagonist.
Yeah, it has been trialed. Yeah, it has been trialed, but was not found to be very convincingly effective.
So one question here. Sure. So the only IBAT that is come into the country is the Elobixabat, and off-label use does improve cholestasis, prolonged cholestasis, either due to alcoholic hepatitis that we see, or we have a lot of CAM-DILI as well, or even primary biliary cholangitis. It does improve the cholestasis and the itch. Any studies on it?
No, the only agent that has been trialed are Volixabat and Linerixibat. Marixabat and Odevixibat has been approved for PFIC and Alagille syndrome. So as for now, for adults, PBC, and we don't have any data regarding other causes of cholestasis.
I think thank you very much for your fantastic lecture, and this we'll end this session here.
Thank you, sir. So for our next session, the moderators are Dr. Mandhir Kumar, Dr. Arvind Joshi, Dr. Lavkesh Anand, Dr. Jatin Agarwal, and Dr. Bikal Ghimire. And the chairpersons, Dr. Satya Prakash B. Subaraj, Dr. Ramesh Satarkar, Dr. Karna Rajvanshi, Dr. Pramod K. Yadav, and Dr. D.K. Singh. And our first speaker will be Dr. Anup Sarai.
Respected chairpersons and members of the House. At the outset, I would like to thank the organizer for inviting me for this meeting. And I'll be discussing treatment of intrahepatic cholestasis of pregnancy over the next 10 minutes. As we know, this is the commonest pregnancy-specific liver disease. Incidence is ranges from 0.3 to 5.6%, typically occurs in early third trimester. This is a reversible disease and has adverse pregnancy outcome. Etiology is generally genetically seen in genetically susceptible individuals. Then there is a disbalance of these reproductive hormones, and certain environmental factors are responsible for this condition. The risk factors are high BMI, multiparity, positive family history, past history of cholestasis, because there is 70% chances that in subsequent pregnancy, patient may develop intrahepatic cholestasis of pregnancy. Gestational diabetes, use of OCPs, use of fertility treatment, especially IVF, chronic hepatitis C infection, and cholelithiasis. The presenting symptom is pruritus. This is intense to begin with from the hands and soul, and then it is seen that during night hours it is worse. Rashes are not seen with intrahepatic cholestasis of pregnancy. That's an important point. Patient may have may give history of passing dark urine and pale stools. There may be gastric pain, fatigue, anorexia, or jaundice, which is seen in less than 10% of cases. Jaundice without pruritus is rare. So how to diagnose? In an unexplained pruritus during pregnancy should prompt consideration of ICP, and a maternal fasting total bile acid level of more than 10 micromole per liter or postprandial bile acid level of more than 19 micromole per liter can be diagnosed as ICP. Serum aminotransferase can be used as a biochemical reference marker, but this is not seen in raised levels are not seen in all cases. To establish a diagnosis of ICP, it requires ruling out other causes of pruritus, elevated serum total bile acids, and other laboratory abnormalities, and a routine ultrasound examination to rule out any surgical condition. Now, the second question is to assess the severity of disease, and that severity can be assessed on the basis of clinical presentation, clinical features, and bile acid levels. The maternal fasting serum total bile acid level of more than 10 to 39 micromole per liter, or random sample showing a bile acid level of 19 to 39 micromole per liter is required. Clinical symptoms mainly consist of pruritus without other obvious symptoms in a mild disease. In severe disease, the maternal serum total bile acid level of more than 40 to up to 99 micromole per liter, and bilirubin may be more than normal, accompanied by other circumstances such as multiple pregnancies, preeclampsia, recurrent ICP, and previous perinatal death due to ICP, or early onset ICP. That is also an important point. And then extremely severe ICP when maternal serum bile acid level is more than 100 micromole per liter. These are the adverse fetal outcome which we encounter: fetal growth retardation, premature birth, meconium-stained amniotic fluid, neonatal respiratory distress syndrome, heart arrhythmias, fetal distress, and stillbirth. So as far as role of bile acid is concerned, it helps us in deciding the severity of disease, and the fetal mortality is linked with it. If it is less than 40 micromole per liter, then the fetal mortality is 0.13%. 40 to 99, it is 0.28%, and if it is more than 100, then the mortality is 3.44%. And this has also been shown that all these parameters, in fact, if the bile acid level is high, these outcomes, fetal outcomes, are also showing a worst outcome. So adverse maternal outcome, as far as during pregnancy are concerned, are severe pruritus, sleep deprivation, and anxiety, steatorrhea, vitamin K malabsorption, and risk of hemorrhage, and risk of gallstone disease. And long term, there is high risk of recurrence, gallstone disease, hepatobiliary malignancies, immune-mediated and cardiovascular diseases, and hepatitis C infection. So what are the treatment options which are available? So there are two goals. One is to alleviate symptoms, and second is reducing perinatal morbidity and mortality. So as far as medical management is concerned, the mainstay is ursodeoxycholic acid. This is preferred treatment. Dose is 10 to 15 milligram per kg per day. And the biochemical improvement is generally seen in 3 to 4 weeks' time. If no improvement, then the dose titration can be done, and it can be increased to up to 25 milligram per kg per day. And identifying predictive markers of response to UDCA also very important point, but unfortunately there is very little data on this. And recently there are few papers in which they have shown that high zonulin level and increased intestinal permeability may be associated with poor response to UDCA. Mode of action, as we know, that it stimulates bile acid secretion, and then also alter post-transcriptional mechanism leading to rectification of impaired hepatocellular secretion, stabilizes cell membrane, and immunomodulatory effect. So this is a study in which the 454 patients this is a systematic review of 9 published randomized trials where they have clearly shown that UDCA is effective in reducing pruritus and improving liver test results in patients with ICP. And as far as fetal outcome is concerned, there are also some benefit, but the confidence interval is pretty high, so we can't be very sure about it. Ursodeoxycholic acid versus placebo in women with intrahepatic cholecystitis of pregnancy. Again, as this randomized trial in which 650 women were randomly allocated to 2 groups, one getting UDCA, another placebo. So in both the groups, there was not much of a difference as far as composite fetal outcome is concerned, and treatment with UDCA doesn't reduce adverse perinatal outcome in women with ICP. Same results again from Cochrane review, 26 trial, 2007 women, and 9 different pharmacological interventions were compared. The 2 placebo-controlled RCTs of UDCA of 715 women were at low risk of bias. Compared with placebo, UDCA probably results in a small improvement in pruritus score. Evidence for fetal distress in stillbirth were uncertain due to serious limitation in study design and in precision. Again, this is another systematic review where UDCA effect on prevalence of stillbirth was observed. 85 studies included, 6974 women in 34 studies were analyzed, of which 4726 took UDCA. Stillbirth in ICP treated versus untreated were almost same, 0.7% and 0.6%, and UDCA has no effect on prevention of stillbirth. So UDCA, no effect on prevalence of composite outcome in all these studies. This is another trial, terrific trial, where an outcome of treatment in the severe early onset ICP was comparing standard UDCA therapy with rifampicin. The results are still not out. Other drugs which can be used, second-line drugs, rifampicin, acetylmethionine, cholestyramine, and aqueous cream, lotion, antihistamines, and vitamin K for coagulopathy. Dexamethasone may be used for promoting fetal lung maturity. These are other clinical studies. In fact, I'll come to the, these are other drugs which have been tried. IBAT inhibitors, intestinal bile acid transporter inhibitors. In fact, only one study is there in the literature, but again, only in 4 cases, this was used in 4 patients, and results were good, but no randomized trial is available till date. FXR agonist, also not tested in pregnancy. These were used in other conditions, other cholestatic conditions, and nor UDCA, again, not tested in pregnancy. 4-methyl butyrate, these are all experimental studies, and there are no other studies with any other agent. Artificial intelligence has probably influenced the diagnosis of ICP to provide adequate and early intervention, and various mechanisms for learning model based on many factors were developed, and area under the curve for top 5 models ranged from 0.9 to 96%, and one of their model predict ICP with accuracy in 90.50%. As far as fetal surveillance is concerned, routine fetal surveillance with non-stress test and biophysical profile can be done, but not for the diagnosis of ICP. It doesn't predict stillbirth. We can use it, but it doesn't predict stillbirth, and reliance on NST should not delay indicated deliveries. Daily fetal movement counting should be encouraged as a low-cost patient-centered tool, and in case of total serum bile acid of more than 100 micromole or coexisting high-risk obstetric conditions, individualized surveillance strategy may be considered. As far as maternal fetal monitoring is concerned, in mild ICP, recheck total bile acid at 1 to 2 weeks interval until delivery. In severe and extremely severe ICP, recheck once a week until delivery, and monitor the in utero condition with fetal movement, electronic fetal monitoring, and ultrasound examination. However, fetal monitoring cannot reduce the occurrence of stillbirth. Timing of delivery, these are various guidelines, and in fact, in severe disease, we can induce labor at 35 weeks, and in mild disease, we can wait even up to 39 weeks. Mode of delivery, intrahepatic cholestasis pregnancy is not an indication for cesarean section. This is important. And We should plan and induce labor and termination of pregnancy via vaginal route. Severe and extremely severe ICP, fetal monitoring to be closely observed during vaginal birth, and continuous electronic fetal monitoring may be necessary. Fetal monitoring repeatedly show abnormalities, then this is a weak indication for cesarean section. Follow-up after delivery, maternal serum total bile acid and LFT should be assessed. Improvement in pruritus is an important symptom that can settle in 4 to 6 weeks' time. In case history of ICP is there, then potential recurrence in subsequent pregnancies should be observed, and estrogen-containing OCPs to be avoided. Early pregnancy screening for with total bile acid and LFT should be done, and upon diagnosis, early alternate monitoring and management should be considered. So in summary, it is a disease of third trimester, reversible disease, adverse fetal and maternal outcome, high index of suspicion even with LFT are normal, and monitoring with bile acid levels should be done. UDCA is the first line of treatment, and early delivery at 37 weeks is recommended. The recurrence rate is around 70%. Thank you.
Thank you, Dr. Saraya. Just one question. You said UDCA is the first line. What would be your second line treatment? Because so many patients do not respond to do not respond in itching.
In fact, there is no evidence we can try rifampicin. We are waiting for that result of that study. Rifampicin has been given in a randomized trial with UDCA. You can use cholestyramine, you can use emulants, you can use anything, but there is no evidence in support of any of these second line drugs.
But, given a choice, what do you use?
I will give emollients or I will give cholestyramine, but again, there is no
definite study.
Thank you, sir. So now I would like to invite our second speaker, Dr. S.P. Singh.
Respected chairpersons and friends, I am going to speak on the subject allotted to me, which is relevance and contribution of individual metabolic risk factors in MASH. When Anil gave me this subject, he said it's very important. So after reading the subject, this riddle came to my mind. If a chicken and a half lays an egg and a half in a day and a half, how many eggs will 3 chickens lay in 2 days? Because the risk factors in MASH or NASH, whatever you call it, are so intricately related that to separate them into what each one is responsible for is, for me, it is extremely difficult. What are first the metabolic risk factors? I am not sure about that also. But generally people consider these to be the, the risk factors which constitute together the metabolic syndrome, obesity, especially central obesity in a part, high blood pressure, high blood sugar, atherogenic dyslipidemia. These were the main ones. Now, metabolic risk factors became more important, because, it went on, we were hammered, there is this metabolism, and, NAFLD suddenly changed into, depends upon whom you are supporting. Like, politician, whom Congress or BJP. So, MAFLD or MASLD. And then relevance and contribution to what? Because earlier on, we always, concentrated on the liver part. Now we realize it's a disease where all the systems in the body are involved. So the two main ones are, the most important is cardiovascular. So whether it's contribution to the cardiovascular problems or disorders or to liver-related events, that's again a problem. If you look at the causes of death, these patients are more prone for compared to the normal population. The most important is not liver-related, it's cardiovascular. So probably what is expected of me is, it's effect or contribution to cardiovascular problems, coronary artery disease, and liver-related events, cirrhosis and HCC. This term or entity gained importance following this, fracas between the two groups. One said the name should be MAFLD, and they had these, metabolic risk abnormalities, they said. 7, if 2 out of 7 are present, then they think of MAFLD. Then we had the Western group, European, American, and India has also, the Indian hepatologists have also joined the bandwagon. So 5, these are the conventional ATP3 factors. In addition, MAFLD had 2 more, one was CRP, the other was HOMA. Before I go on any further, a bit about this small study we had done. We looked at, we thought that from our practice or from the experience that probably an echogenic liver or fatty liver is a better indicator of insulin resistance than ATP3, that is metabolic syndrome. And actually we found that also. What we found was that patients with NAFLD higher, NAFLD alone is a better predictor. It was more sensitive and more specific for identifying insulin resistance than the ATP3 criteria, that is 3 out of 5 if present. Actually, I had proposed this in one of the EASL meets also. I asked them to change the definition of metabolic syndrome and include fatty liver in that. And then we did, 2 small studies in a part of the world, and we looked at the so-called dysmetabolism, which they called. How many of a normal population who do not have fatty liver disease, who do not have fatty liver, who have a normal looking liver, what proportion of them have actually dysmetabolism according to these 2 criteria? And we were surprised to see that if we applied the MAFLD criteria, 1/3 of our population had dysmetabolism. And when we applied the MASLD criteria, almost 8 out of 10 males had dysmetabolism and almost 100% females had it. So can this be a criteria? It is like, making, supposing you have blood sugar more than 75, you are diabetic. Your entire population is then labeled diabetic. So these criteria are very, I don't agree with them. It's like, the magician pulling out a rabbit from the hat. They have pulled it out and then created these labels. We published this in 2015. We were looking at risk factors. And surprisingly, what we found that in addition, the risk factors which we found were associated with sedentary lifestyle, obesity, consumption of meat, fish, spicy food, fried food, and tea was important. Tea, because most Indians, they take a lot of tea with sugar and milk. So that was why people who drank tea had more often NAFLD. And on multivariate PCA, waist height ratio and BMI were significantly higher in the NAFLD patients. So basically what I want to say is, the most important thing is obesity. Disbalance between energy consumed and energy expended. That's all. We did another small study looking at simple anthropometric indices like waist circumference, waist height ratio, and what we found was that the waist height ratio was a better predictor measure for interpreting presence of NAFLD than BMI with a sensitivity of 100% and specificity of 82%. So this is again, study where we looked at normal people who came to us for different disorders, and we looked at the incidence of NAFLD, and what we found that these so-called risk factors, what was the prevalence? Almost 2/3 of our patients had them. So again, back to the same slide. So the most important thing is not liver-related events, cardiovascular events. And liver-related events or morbidity, mortality only measures up to 1/4 of the cardiovascular disorders, and we are all talking about liver-related events. Now, this is a recent study published in probably December last year, differential prevalence and prognostic value of metabolic syndrome components among patients with MASLD. So probably this is what the people who organized this meeting expected me to talk about, I thought. And here what we found was, when the data was analyzed and adjusted for age and sex for the association of the presence of individual risk factors on mortality in participants with MASL, as the number of risk factors increased, so also the complications, different types of, whether it was cardiac, whether it was liver related, they increased. If you had 2, it was less, and as it increased, the hazard ratio went on increasing. So metabolic syndrome components impact survival and risk of fibrosis incrementally. Hypertension was associated with the highest risk of all-cause mortality. The associations between cardiometabolic disorders and mortality attenuated with increasing age, and an increased waist circumference had the strongest association with fibrosis, as we had also shown earlier. This is a survival analysis of patients with MASLD stratified by the number of cardiometabolic disorders. As the number of cardiometabolic disorders increase, the mortality goes up. Again, this is the results obtained from logistic regression analysis for the risk fibrosis and cumulative number of disorders or the risk factors among MASLD population, and this says the same thing. As we have an increase in the number of criteria or the risk factors, fibrosis increases also. So each of the cardiometabolic disorders or the risk factors has a differential association with all-cause mortality and liver fibrosis. Among the risk factors, especially regarding mortality, hypertension amongst them was identified as the most potent and consistent independent predictor of all-cause mortality across all age groups, but especially if in the younger people between age 20 and 40 years. In addition, hypertriglyceridemia and also prediabetes or raised blood sugar was also associated with increased mortality amongst the different factors. But when you come to the risk of fibrosis, there was, as shown, incremental increase, but in the current study they showed that increased waist circumference emerged as the strongest predictor of fibrosis, followed by prediabetes and hypertension. Next to this, which is there in the metabolic risk factors mentioned by the MASLD group. Now, CRP is primarily produced by hepatocytes in response to increased levels of pro-inflammatory cytokines, and it increases an inflammatory milieu in the body. This study clearly shows that if you have, you have a high CRP, so also, the severity of fibrosis and also the cardiovascular problems increase. This shows with the increased levels of CRP, you have more fibrosis. Again, this study showed if you have, the high sensitivity CRP was associated with heart failure in patients with MASLD who are followed up over a prolonged period of time, especially those with normal ejection fraction LVF. To end this, I would like to highlight this study. Lifestyle intervention is effective in reversal of fibrosis in NAFLD patients. We only targeted 2 things, consumption and sedentary lifestyle. We asked them to do nothing else. None of these, new fashionable medications. We told them to walk every day for 1 hour, at least 5 days a week, and we asked them to gradually reduce their diet to 50% of their normal diet which they take. We didn't tell them anything else, because we found that when we told them a different type of diet which they were not used to, they didn't stick to that. So we told, if you are taking roti, chawal, bhat, whatever you take, just reduce it by 50%. And what we found was almost all the parameters went down. The weight went down, BMI, waist circumference, hip, and most important thing is weight reduction was, this is 1 year's data. Weight reduction was observed in 85% of patients, decrease in liver stiffness observed in 2/3 of the patients, 1-stage reduction in fibrosis in 40%, and a 2-point reduction in liver stiffness was observed in half of the patients. None of them developed any liver-related complications of NAFLD. So I am back to the same riddle. If a chicken and a half lays an egg and a half in a day and a half, how many eggs will 3 chickens lay in 2 days? So it is very difficult to separate and unnecessarily complicate the whole issue of the risk factors. Simple risk factors are two to me: sedentary lifestyle and amount you eat. Very simple, reduce that and that's the end of your disease. Don't go in for anything else. And if you, as someone has said, that if you torture data enough, it will confess. You have all these papers, publications, you have high H index going up, you have impact factor going up, but the result to the poor patient is zero. Thank you. Any question? No?
Questions will be after the
Okay.
conclusion of session.
Okay. Thank you.
We would like to invite our next speaker, Dr. Manish Bhatnagar.
Good evening to all seniors, teachers and friends in the audience. My sincere thanks to Professor Arora and his team for this wonderful opportunity. I'm supposed to be talking on drug-drug interactions in chronic liver disease. What should a gastroenterologist know? And let's quickly dive into the topic. So this is the problem statement and the status as it exists right now. The percentage of patients with potential drug-drug interaction and no potential drug-drug interaction basically depends on the child puke classification. There's an age distribution gradient, and as we see, this is something which gastroenterologists should care about because we prescribe a lot of drugs like anti-ulcer agents, laxatives, antiemetics, hepatoprotectives, cholagogues, and probiotics. And if you look at the percentage of these drugs, GI drugs outrank antibiotics quite significantly, and most of us tend to believe that these are quite safe drugs. But in the setting of chronic liver disease, that may not exactly be the case. And the reason for that and the significance and the scope is that when you give a drug orally, there is a protein-bound and an unbound component in the systemic circulation, which has a drug receptor interaction. It is dependent on the metabolism in the liver, which is intricately linked with the metabolism in the gut through the portal vein. Also, the problem of polypharmacy is present in more than half of the cirrhotic patients, with rises with age and the disease severity, and adverse drug reactions occur in about 28% of the cirrhotics, and nearly 22% of the patients experience drug-drug interaction, and some of these even lead to hospitalization and bad outcomes. So why is it important? It is important to avoid polypharmacy in any case, but why is it critical in cases of chronic liver disease? It's basically because there are potential changes in the drug's disposition in the cirrhotic patients, because when you have liver cirrhosis, you have reduced hepatic blood flow. This makes for higher bioavailability and serum levels increase. There is reduced protein, so this increases the serum concentration of the free drug. There is the presence of ascites, which has an effect on the half-life. There is bowel edema, which impairs absorption. There is reduced P450 cytochrome activity, so reduced first-pass metabolism or clearance. And then, of course, you have impaired renal excretion, which increases serum concentrations. One must also keep in mind that you are dealing with portosystemic shunts, and this increases the bioavailability because it reduces partially or completely the loss of first-pass metabolism and is known to cause prolonged QTC interval in the specific drug sets, which we'll see. So if you look at this sequential progressive model of hepatic dysfunction, the normal hepatic function when the plasma clearance is 100%, the CYP450 activity is normal. With mild dysfunction, the clearance of drugs metabolized by sensitive CYP isoforms changes, and the CYP2C19 is highly sensitive and it shows marked activity reduction, whereas the CYP2E1 and CYP2D6 are relatively preserved. With moderate dysfunction, you will have further decrease in CYP450 activity for most isoforms and impaired metabolism of several drugs. And with severe dysfunction and decompensated cirrhotics, you will have a marked reduction in plasma clearance and widespread CYP450 suppression associated with a hepatorenal syndrome. So liver diseases have their effects on the pharmacokinetics as well as the pharmacodynamics. So there are various types of DDIs that are the drug-drug interactions. So you have the additive or antagonistic clinical effects, which are seen in our very commonly prescribed lactulose with mycophenolate leading to diarrhea. Pharmacokinetics, where the absorption, distribution, metabolism and elimination alterations are very critical in CLD. And if you look, this is, I won't even try to pretend that I understand this slide very much, but this is how, how complex the liver metabolism is, and this whole metabolism actually changes when the patient has chronic liver disease, and the membrane localization of the hepatic transporters involved in the hepatobiliary disposition of drugs and metabolites undergoes a significant change, and this definitely has huge effects on the systemic drug clearance, and therefore one must be very, very aware of the adverse reactions which can occur. Since the topic for this particular module was beyond the guidelines, I'll just briefly touch upon these transporters in liver disease which show decreased expression, increased expression and other alterations. Suffice to say in summary that all these things are complex, but they are usually flying below the radar because we do not recognize this and we end up prescribing things. So there is a clinical impact of what we prescribe, and why we must care is because enzyme expression changes. It increases the sensitivity to inhibitors and unpredictability with inducers, and when you use drugs with narrow therapeutic index drugs like calcineurin inhibitors, antiarrhythmics, they carry the highest amount of risk, and in CLD patients it can occasionally have very bad outcomes. So let us look at a few common GI drugs and interactions. When we talk about PPIs, which was extensively discussed early in the evening, omeprazole, all of us have used. It inhibits the CYP2, C19, and it decreases the clopidogrel activation. When you use H2 blockers, cimetidine inhibits multiple CYPs, whereas famotidine has minimal effect, though it is not completely safe. And then of course you have the prokinetics like metoclopramide, which increases the diazepam levels, interacts with CYP2, D6 inhibitors. So these are very common drugs which are almost the norm. At least one of them is the norm in most of our prescriptions. Then coming to macrolides, which is again a high-risk drug class in CLD, it has potent CYP3A4 inhibition, which leads to increased QT prolongation and increased calcineurin inhibitor levels. If you look at the antiretroviral drugs, the protease inhibitors, the tenofovir, the boceprevir strongly inhibit the CYP3A4, cause massive increase in tacrolimus and cyclosporin exposure. And when you use antifungals, one has to be extremely careful because they again inhibit CYP3A4 and increase the toxicity of statins and benzodiazepines if the patient's on them. Then comes the class of cardiovascular and CNS drugs. You have amiodarone, which is a big favorite with cardiologists. This is something which is extremely dangerous in the setting of CLD. It inhibits CYP3A4. This increases the warfarin and simvastatin exposure. Benzodiazepines are anyway something to be avoided in most patients with CLD. SSRIs again increase toxicity of various drugs including metoclopramide. So what are the clinical consequences of polypharmacy? I think a lot of us are guilty of doing this, either advertently or inadvertently. We must understand that MRPs, which are the medication-related problems, they are found in about 1/5 of the cirrhotics. They are linked to disease severity and inappropriate dosing. ADR-related admissions commonly involve diuretics, which lead to precipitation of hepatic encephalopathy, HRS, NSAIDs, which can lead to GI bleeds, and sedatives, which will also precipitate HE and all. So these are the examples of medicines with clinically important PK/PD changes in cirrhosis. I'll not go into too much detail for want of time, but suffice to say that we are dealing with fairly commonly used drugs, like metoclopramide, pantoprazole, weak opioids, codeine, tramadol, NSAIDs, clopidogrel, rivaroxaban, statins, nifedipine. I think the list can go on. Psychotropic medication is usually not used in CLDs, but sertraline, zolpidem, melatonin and all, we know that there are these problems. So once we have identified this problem, how are we going to avoid this? So medication management has to be titrated. Interventions have to be made in cirrhotics, and their impact on clinical outcome has to be a multifactorial and a multifaceted approach. You must have patient-oriented interventions. The patient should also be educated about the risks of polypharmacy, improve their knowledge, self-care and quality of life. There are multiple RCTs which have said that increasing knowledge decreases unplanned admissions by nearly half, and 68.9% resolution of high-risk medical-related problems is possible if patient-oriented interventions are promoted. Then there are pharmacist-led interventions where the pharmacist is also part of your team, and medical reconciliation and optimization of therapy along with high impact on MRP resolution and safety is reported. Finally, you have the technology-driven interventions. AI and everything is now a reality, and now remote management via apps and telehealth also improves monitoring, and this of course needs validation through bigger trials, but it is something which is quite exciting. And finally, something which all of us need to practice is deprescribing in CLD. Frailty and limited life expectancy warrant deprescribing, and deprescribing of unnecessary drugs reduces falls, hospitalization, mortality. The focus has to be on stopping NSAIDs, PPIs, benzodiazepines when inappropriate. So these are the key recommendations for the gastroenterologist: early identification of medication-related problems, integration of the pharmacist in your care teams, use of technology for monitoring and education, and regular deprescribing and revisiting your prescriptions to do dose adjustments. As it is said, all things are poison and nothing is without poison. The dosage alone makes it so a thing is not a poison. Thank you very much.
We would like to invite on stage our next speaker, Dr. Sanjay Satpathy.
All right. Good evening. Good evening, everyone. I would like to thank Dr. Arora, Dr. Anil Arora, Dr. Ashish Kumar, and Dr. Praveen Sarma, and the entire organizing team for the opportunity to speak. My topic today is sarcopenia and frailty, clinical implications. Particularly, I'll focus in patients with advanced liver disease and transplant evaluations. In the next 15 minutes, I will cover what sarcopenia and frailty are, why they matter in cirrhosis and transplantations, and how we can integrate this knowledge into clinical practice. So let me start with a clinical vanity. We have a 58-year-old male with a decompensated MET-ALD related cirrhosis, has an incidental 1 centimeter HCC, MEL score is 15, and he is able to walk about 180 meters under 6 minutes. His LFI, which is the liver frailty index, is 4.8, which puts him into the frail category, and his SMI, which is a skeletal muscle index to measure the sarcopenia, is 40, which puts the patient into the sarcopenia category. His comorbidities are diabetes and obesity. His BMI is 31. So his patient's son is willing to be a living donor. Now, in this scenario, is MELD enough to capture his risk of mortality and liver transplantation? Would you consider listing at MELD 15 given that his son is ready to be a living donor, or wait for a higher MELD score? Does sarcopenia, frailty, and the comorbidities alter your view on his transplant candidacy and his risk beyond MELD score? With a 1 centimeter HCC below the threshold for a MELD exception, should you wait and monitor or pursue early transplant planning? These are all the questions in my mind which I'm going to go through while I'm presenting my slides in the next 15 minutes. Now, does sarcopenia and frailty add to his risk? In order to understand this, let's understand what is sarcopenia. Sarx meaning muscle, and penia is meaning loss. So loss of skeletal muscle mass is what defines sarcopenia, and it is measurable, and it is diagnosed by imaging like CT, MRI, or DEXA scan. Now, frailty is a broader term. It reflects a global decline in reserve across multiple domains. It includes sarcopenia, but also nutrition, cognitions, and daily function. You can see here in this diagram how sarcopenia contributes to frailty and how both are driven by complex web of factors, that is inadequate nutrition, inactivity, comorbidities, aging, and ultimately worse outcomes like recurrent hospitalization. So frailty is the bigger picture, and sarcopenia is one important piece of it. This is a meta-analysis that estimates the sarcopenia prevalence in cirrhosis patients using data from 23 studies. Sarcopenia rates has varied from 15% to near 70% among the different groups. The pooled prevalence is 37.5%. So this indicates that over a third of the cirrhotic patients also suffer from sarcopenia, highlighting the critical role of muscle loss in liver disease and the need for early detection and intervention. Why should we as clinicians care about sarcopenia and frailty in cirrhosis? Now, as we already talked in earlier slides, 70%, up to 70% cirrhotic and up to 1/3 cirrhotic in general and transplant candidates have sarcopenia. And it is particularly prevalent in alcohol-related liver disease, as you can see in this slide. Almost 49.6% compared to the non-alcoholic patients, like 33%, has sarcopenia. In addition, as the disease progresses from child A to child C, the prevalence continues to increase. And we have also shown on the right side of the diagram, the survival is also significantly reduced in sarcopenia compared to the non-sarcopenic individuals at 1, 3, and 5 years. But most importantly, unlike MELD, sarcopenia and frailty are modifiable and with nutrition, exercise, and prehabilitations. So this gives us a real chance to change the outcomes. This slide underscores sarcopenia as an independent risk factor for poor survival in cirrhotic patients, especially those with a low MELD score. Here you can see the Kaplan-Meier curve shows that patients even with a low MELD score of 15, and if they have sarcopenia, they have the worst outcome or worst mortality when they have these combinations over time. So this slide emphasizes the importance of addressing muscle wasting in cirrhotic patients, particularly those with a lower MELD score, to improve their survival, because these are patients who might be waiting longer and may have more complications during their follow-up times. Now this slide underscores this slide shows the impact of sarcopenia in liver transplant recipients. Survival after transplant is not significantly different between sarcopenic and non-sarcopenic patients. However, sarcopenia is linked to longer hospital stays, about 40 days versus 25 days, and a higher risk of bacterial infections in the first 90 days. Importantly, the viral and fungal infections are not different. So while sarcopenia does not reduce overall survival, it contributes to more complications and resource utilization following liver transplantations. That is a single study, but if you look at the meta-analysis, here is a study that summarizes 19 studies, including 3,803 patients. On the waiting list, sarcopenia increased mortality risk with a hazard of 1.72, and post-transplant it raised the mortality risk with a hazard of 1.84, and the low skeletal muscle correlated with higher mortality following transplantations. So sarcopenia is a significant predictor of poor outcomes, independent of MELD score, emphasizing the need to address the muscle loss. This is a study, again looking into a living donor liver transplant perspective, 2,800 LDLT recipients, and it has shown that patients with sarcopenia, there is a significantly higher graft failure at 180 days and long term. And their survival is also significantly lower, both at 180 days and long term. In short, sarcopenia strongly predicts graft failure and mortality after living donor liver transplantations. Now, this is a study that looked at the relationship between the tumor burden and frailty in liver transplant candidates with hepatocellular carcinoma. Interestingly, frailty was actually more common in non-HCC patients compared to those with HCC. Among the HCC group, frailty was not linked to the tumor-related factors such as the number of lesion, the tumor size, and alpha-fetoprotein level, and prior treatments. Instead, frailty was tied to markers of underlying liver disease severity, including higher MELD score, hepatic encephalopathy, obesity, and female gender. The key takeaway is that HCC patients, frailty reflects the state of the liver rather than the cancer itself, underscoring the need for HCC-specific research. I would like to introduce a concept here. Oh, before that, this is a study that actually looked into the in our patient, if you remember, our patient is sarcopenic, is not also obese. These are patients who not only have muscle loss, the sarcopenic obese patient, they have a poor quality muscle. There is infiltration of steatosis or fat into their muscles. And here this is what one of the study that looked into 433 patients, multi-center study, they showed that myosteatosis and sarcopenia goes hand in hand. Patients with both sarcopenia and obesity, sarcopenia and myosteatosis are associated with significantly reduced survival at 1 year. In contrast, patients without muscle alteration fared much better. So the takeaway is very clear. Combined sarcopenia and myosteatosis identify a particularly high-risk group where early recognition and intervention would make a difference. Now I want to introduce a term, the gut frailty. And recent studies have shown that gut health plays a pivotal role in the unhealthy aging and degenerative diseases impacting frailty. Gut microbiota imbalances, which is known as dysbiosis, can worsen malnutrition and gastrointestinal issues in frail individuals. The gut muscle and gut brain connections indicate microbiota's influence on physical frailty, sarcopenia, and cognitive decline, leading to the concept gut frailty. This evolving idea suggests diet, microbiome targeted therapies, and exercise as potential treatments, highlighting the multifaceted nature of frailty in liver disease and beyond. This is a slide illustrating the complex relationship between the liver cirrhosis, sarcopenia, and dysbiosis. On the right side of the diagram, we see the role of dysbiosis in liver cirrhosis. Dysbiosis refers to the imbalance between the beneficial and the harmful gut bacteria. In cirrhosis, we observe reduced bacterial diversity, increased intestinal permeability and bacterial translocations, and increased levels of the endotoxins and harmful byproducts due to small intestinal bacterial overgrowth. These factors further exacerbate liver cirrhosis, complications, promote inflammation, and ultimately accelerate muscle loss and the progression of the sarcopenia. So overall, the gut dysbiosis and muscle breakdown and the liver cirrhosis are quite interconnected, influencing the progression of the liver disease. How do we assess sarcopenia and frailty? There are three domains. The loss of muscle mass is measured by most commonly through CT or MRI using the skeletal muscle index measurement at L3 vertebra level, and reduced muscle function measured by liver frailty index and 6-minute walk distance, and the reduced muscle strength is measured most commonly with hand grip strength. There are various other measures which I have highlighted, but I won't go through those in details. Now this slide shows the anatomical location that is most commonly assessed in muscle mass studies. Many focus on the psoas muscle either by measuring its diameter or by calculating the skeletal muscle index at the L3 vertebra level, either at the end plate or the mid body. This includes not just the psoas but also the muscles such as the erector spinae, quadratus lumborum, transverse abdominis, and internal obliquus. Traditionally, this requires a manual annotation which is time intensive and prone to variability. In view of this, at our center we have designed an automated skeletal muscle index measurement methods using deep learning methods, and we've been successfully able to automate segmentations and improve its reproducibility. The middle image shows the muscle highlighted in red, and the right side you see the neural network architecture used to train the model. This approach holds promise for rapid standardized sarcopenia assessment in clinical practice. The manuscript is currently under review and it is still not published. Now, how do we assess liver frailty index? Liver frailty index is the most widely adopted tool for assessing frailty in patients with cirrhosis. It is based on three simple bedside measures: grip strength, mean of 3 trials, chair stance, time to rise from chair 5 times, and balance holding 3 positions up to 10 seconds each side by side, semi-tandem or tandem. And then the results are combined into a score, and the patients are then categorized into robust, pre-frail, or frail. What makes the LFI or liver frailty index particularly useful is that it's objective, it's reproducible, and it is predictive of waitlist mortality, independent of the MELD score. Again, combining the liver frailty index with MELD score further improves the accuracy of mortality at 3 months. This has been shown in this study. And also on the right side, the cumulative incidence of mortalities in high-risk groups with high LFI and high MELD score is significantly higher as compared to those who have low LFI and low MELD score. So this highlights The graph highlights the mortality risk rises in a graded fashion with higher LFI scores and underscoring the importance of including frailty in the evaluations. This slide evaluates the combined use of, again, the liver frailty index and the MELD sodium score. As we have seen, the liver frailty index is a powerful predictor of outcomes, but how do we apply it in clinical practice? First, it helps with the risk stratification, distinguish frail from non-frail patients, and adding prognostic value beyond the MELD score. Second, it informs transplant candidacy, highlighting patients at higher risk and those less likely to benefit. Third, it creates opportunities for prehabilitations, tailoring nutrition, exercise, and therapy to improve status before their surgery. Finally, it predicts post-transplant complications, hospital stay, and survival. This slide highlights the impact of the 3-month change in the liver frailty index on waitlist mortality. Patients who improved their frailty status, which is about 16% patients who improved, 7.3% mortality at 2 years. And those who had worsening, 12.1% of those patients, significant worsening in their mortality. So this key message is that even short-term mortality changes are highly predictive. Improvement lowers the risk, and while worsening, especially severe, greatly increases their mortality, and monitoring frailty trends is essential for better outcomes. So despite, in our case, Mr. R, the low MELD, his functional and nutritional reserve is low, his high risk of waitlist dropout, infections, and longer length of stay following the liver transplantations. And we need to intervene in these patients. And this is the image that outlines the potential therapeutic targets to treat sarcopenia and cirrhosis by focusing on many interconnected factors. The most important one here I would like to highlight is by nutrition intervention, by improving their nutritional status, supplementing branch-chain amino acids, optimizing their cirrhosis care to reduce their bacterial translocations, and lowering ammonia level, which actually stimulates myostatin, which promotes muscle degradation. So reducing ammonia will reduce their muscle degradations. This infographic summarizes a study on prehabilitation effects on frailty and survival in patients with advanced liver disease. 517 patients, here they have shown significant improvement in their outcomes by improving their frailty. Testosterone level is also very much correlated with liver frailty in a multivariate analysis. So the key is low testosterone is an independent predictor of frailty in advanced liver disease. And this is a home-based liver frailty program that has been very much useful in patients and has shown a significant improvement in LFI. And this is just the testosterone level that I just mentioned about. Now, targeting frailty in liver transplant candidates. We have to focus on nutrition, exercise, and prehabilitations, multidisciplinary approach, medical optimization, and ongoing monitoring. So in our patient, Mr. R, who underwent, who actually were enrolled into a structured nutrition and exercise program, and over 3 months his LFI improved. He could walk 355 meters, and patient was subsequently underwent a living donor liver transplant, his son being a donor with a good outcome. And I want to point out just 2 slides. In this study, authors asked an important question: does frailty negate the survival benefit of liver transplantations? Using data from multi-center frailty study that compared pre and post liver transplant mortality across frailty levels, they found that as the liver frailty index increased, both pre and post transplant mortality rose. However, the impact was far greater before transplantations. Even among frail patients, liver transplantation consistently provided net survival benefit, and there was no frailty threshold where the risk outweighed the gains. So in short, while frailty identifies high-risk patient, transplant still improves survival across spectrum of the frailty. So the key takeaways is impact of addressing frailty and sarcopenia. It improves waitlist survival, enhance post-transplant recovery, reduces hospital stay and complication, reduce mortality, and empowers patients and families with shared decision making. And thank you very much, and I can take a few questions.
Thank you, sir. Wonderful talk. So we all are aware that sarcopenia frailty definitely impacts cirrhotic patients and the transplant. So, and you also have showed in your example that you waited for 3 months to improve the frailty and then you proceeded for transplant. So, my question from a practical point of view, that if there is a decompensated cirrhotic patient who has a living donor who is willing to donate, and the patient is definitely needing it. So how long do you think you are going in for this to wait for the improvement in the frailty before you say no, now we can go ahead? Because of course the last slide showed that it is not a contraindication, but it can improve. But is there any time point that you will wait?
And secondly, how often the measures improve frailty?
I think those are great questions. The first, so the question here is, do we have enough time to get this patient optimized enough to make them a better candidate as a transplant candidate? You know, this is the question that you have to answer by looking individually at each patient. If the patient does have time, meaning the patient has a low MEL score and still being able to be seen as an outpatient, and then you have a time to work on these patients and improve their frailty, and it may take a few months to optimize them. But if a patient is in the hospital, inpatient side, you do not have that much of time. But these are patients usually a much higher MEL score when they're patient in the hospital. But there are patients with a lower MEL score, with recurrent ascites, and relatively lower MEL score, and where you have 7 days or 2 weeks time to optimize them. In our center, we put a nasogastric tube in these patients. So we try to improve their nutrition. We check their frailty every 7 days. They get intense physical therapy as well as dietitian interventions to improve their outcomes. But this is not a contraindication, as I showed. Even with the decompensated cirrhosis, even they are frail, there is no frailty threshold that you cannot do a transplant. You can, but we need to get an informed decision, and the family needs to understand the potential outcomes of this and the longer hospital stay, potential infection after transplant. And the team has to make a decision as to, are we going to take that hit?
Another subset which is very important in this frailty is the patients who have refractory ascites or gross ascites, because in them the muscle loss is quite high, and of course that also prevents them from doing the regular exercises or other stuff. So do you people over there have any specific interventions to these subset of patients who are more frail and more sarcopenic?
Yeah, so we have a program which is called the STAR Rehab program. There are multiple sites across our our site at Northwell Health. So these patients, when we initially assess in the clinic their liver frailty index, and if the patients are in the pre-frail or frail category, then we refer them through our EMR system, and then the centers actually, they receive those orders and they contact the patient and bring to their centers to get the prehabilitations that we work with this patient. But this patient with the recurrent ascites, they need albumin infusion also. So we do get these patients on a albumin infusion program, and these are patients over time, they do get better and more optimized nutritionally and physically. Thank you very much.
Yes.